Now we move to diabetes. Diabetes in pregnancy is any time glucose intolerance is diagnosed while she is pregnant. So that could include new onset of type 1 diabetes or new onset of type 2 diabetes during pregnancy. Most of the time, it is our typical gestational diabetes, which goes away after the pregnancy is over. Here's our case. A 32-year-old Hispanic multigravida is 29 weeks gestation. Does she have any risk factors for gestational diabetes? Number one, age over 30, higher risk of gestational diabetes. Ethnic group, Hispanic women are at a higher rate, a relative risk of 3 compared to Caucasian women for gestational diabetes. Her 1 hour 50-gram oral glucose tolerance test is 175 milligrams per deciliter. The upper limits of normal is 139, so she has a positive diabetes screening test. Then her body mass index. She is 60 inches tall and weighs 200 pounds, so she has a high BMI. That's another risk factor for diabetes. Her pregnancy weight gain has been 30 pounds. Previous babies weighed 3,800 and 4,200 grams. A previous macrosomic baby is another risk factor for diabetes in pregnancy. So she's got many risk factors. Let's take a look at what is important. Firstly, gestational diabetes is a generic term for any glucose intolerance diagnosed during the pregnancy. After she delivers, if the postpartum glucose normalizes, we will give her a retrospective diagnosis of true gestational diabetes. But if postpartum the glucose values remain elevated, we will be able to say that in retrospect, she had new onset of type 1 or type 2 diabetes that just happened to start during the pregnancy. The reason that gestational diabetes typically doesn't have its onset until 20 weeks is because of HPL, human placental lactogen. Early in pregnancy, placenta is small, only low levels of HPL. But as the HPL levels rise, they are antagonistic to insulin, they increase insulin resistance, and so typically gestational diabetes is diagnosed in the last half of the pregnancy. Who gets screened for gestational diabetes? Every patient who is pregnant. What gestational age? 24 to 28 weeks. What is the test that we use? A 1 hour 50-gram oral glucose tolerance test. Does she need to be fasting? No. It can be done anytime. A normal value is less than 140. If it is 140 or greater, we consider that an abnormal or positive screening test. If she has a positive screening test, the next step in follow-up is a 3-hour 100-gram oral glucose tolerance test. Does she need to be fasting for this? Yes, she does. The laboratory should be instructed that if the fasting blood sugar is over 125, don't give her a glucose load because you already have a diagnosis of overt diabetes. Remember, overt diabetes is diagnosed if a fasting blood sugar is over 125. If you get the fasting blood sugar, it's less than 125, we will give her the 100 grams of glucose. A diagnosis of gestational diabetes is made if 2 out of the 4 values are elevated: fasting, 1 hour, 2 hour, and the 3 hour. This demonstrates why you shouldn't give the glucose load if she has a value over 125. Now these bars in yellow give the normal upper limits for the 3-hour oral glucose tolerance test. Fasting blood sugar should be less than 95, 1 hour less than 180, 2 hour less than 155, the 3 hour less than 140. Now you don't need to remember these for the USMLE because they will give you the normal values on the exam. But I had a patient who came in and she had a fasting blood sugar done and it was 383. The lab somehow missed the boat. They gave her 100 grams of glucose, and what do you think happened? Her 1 hour, 509. Her 2 hour, 582. 3 hour, started to come down a little bit, 458. But this is craziness. Should never have been given the 100 grams because of these horrendously high values. So fasting blood sugar over 125, stop right there. You already have a diagnosis. All right, the diagnosis is made. What is our management? We're going to put her on American Diabetes Association diet, spread the calories equally throughout the meals, encourage complex rather than simple carbohydrates, avoid sweets, candies, cakes. Then we want to monitor her blood sugars, and she can do this at home. The target values that we have are fasting blood sugars less than 90, 1 hour postprandial less than 140. These are euglycemic values. These are normal values that we're seeking. If she is unable to maintain the values in the target range, we will start insulin. And the reason we don't use oral hypoglycemic agents is because we're concerned about fetal hypoglycemia. I might say, however, that there is a new medication, glyburide, which looks very promising in terms of use during gestational diabetes for women who are unable to maintain their blood sugars on diet alone. And I suspect in the next probably year or two, maybe 3 years, we're going to start using this. The rule of 15s in gestational diabetes is 15% of pregnant women will have a positive 1 hour test. Of those women who have a 1 hour test, 15% will have gestational diabetes. 15% of 15% is 2 to 3%. And of those women who have gestational diabetes, 15% will require insulin, which means most women will have a negative 1 hour test. Of those who have a 1 hour test that's positive, most will not have a positive 3 hour. And most women who have gestational diabetes can be controlled with diet. They don't need to go on insulin. If this rectangle represents all pregnant women, 15% will have a positive screening test, the 1 hour. And of those, 15% will have gestational diabetes. So you can see a relatively small number will be diagnosed. And yet, because gestational diabetes is a chemical diagnosis without symptoms, we screen all patients. Let's now move to overt diabetes. This is type 1 and type 2. One of the tests I want to order on the first visit is a hemoglobin A1C, which represents what has been her average control of blood sugars over the previous couple of months. If she has had long-standing diabetes, I want to check and see what are her kidneys doing, get a 24-hour urine collection for creatinine clearance and total protein. I would like to have her eyes assessed through a dilated pupil, do a fundoscopic exam. I don't think you can adequately assess the eye grounds without dilating. And clearly, we want to have home glucose monitoring. And she should be checking her blood sugars 4 to 6 times a day. Fasting blood sugar before and after each meal. That would be ideal. That's a major commitment. And for a woman who has other things to do, this takes a lot of effort and motivation. And many of our patients don't do it, with unfortunate results. This shows what happens in terms of anomalies, malformations, as a function of hemoglobin A1C. 3% if the hemoglobin A1C is in the normal range. And as the hemoglobin A1C goes higher and higher, you can see the malformation risk increases significantly. 3% is about the general population. And women who have overt diabetes who maintain their blood sugars in the normal range during embryogenesis have no higher rate of congenital malformations than do women without diabetes. The fetal anomalies that we see, the big concern has to do with neural tube defects and congenital heart defects, particularly congenital heart defects. And these two organ systems, the central nervous system and the cardiac, are the first ones to develop. And often, these women will have blood sugars that are elevated and they don't even know that they're pregnant, and yet it is doing the baby in. A third anomaly, which is very rare, but is seen 200 times more commonly with women who have diabetes, is sacral agenesis, also known as caudal regression syndrome. This is the X-ray of a newborn that had sacral agenesis. And what I want to direct your attention to is the vertebral column. This is the 12th rib. And you can see that the end of the vertebral column is at L1. There is no spinal column below L1. When you're sitting in your chair, your head, your thorax is supported by your spine, which is attached to your pelvis. There's no attachment of this newborn's body to its spine. And this is a woman who had diabetes out of control. This baby had sacral agenesis, truncus arteriosus, single atrium, single ventricle, total anomalous pulmonary venous return. Bad news. Bad news. Here again you can see the last vertebral body is L1. Can we prevent anomalies in overt diabetes? And the answer is yes. We can prevent both congenital heart disease and neural tube defects, and there's two ways. One, preconception euglycemia. Before pregnancy, control her blood sugars if possible in the normal range. And secondly is preconception folate. And she should be on 4 milligrams a day of folate. Now, all women of reproductive age should be on 400 micrograms or 0.4 milligrams. This is 4 milligrams for women who have overt diabetes. And we need to get this message out. Anomaly screening in overt diabetes, we're going to offer the triple marker screen at 15 to 20 weeks. We're going to do a targeted ultrasound between 18 to 20 weeks. We're looking with the triple marker screen for neural tube defects. With the targeted ultrasound, we're looking for spina bifida and for anencephaly. And if she has an elevated hemoglobin A1C, we'll do a fetal echo between 22 and 24 weeks because increase in cardiac anomalies. The gestational age for delivery. I don't want to see these patients go over 40 weeks because what's going to happen? Muy grande baby, macrosomia, and all of the concomitants of that. Arrest of labor, shoulder dystocia, birth injury. Postpartum complications, because of the overdistended uterus, because of a macrosomic baby, postpartum hemorrhage is more common. So be ready for that. The neonatal problems that can develop include hypoglycemia. And this is because in utero, there has been increased insulin production because of the high blood sugars coming across the umbilical cord. After the baby is born, there's no more glucose coming in from mom, but the insulin doesn't turn off, drives the blood sugars down. And these babies often need to be on an intravenous glucose infusion. Hypocalcemia from an immature parathyroid gland. Polycythemia because of increased erythropoietin generated from intrauterine hypoxia. The placenta can't supply enough oxygen, and so the baby increases its red blood cell mass. Hyperbilirubinemia because the immature liver cannot clear this excessive red blood cells from the polycythemia. And lastly, respiratory distress syndrome because of an immature surfactant. I see many of these diabetic women who are getting big, uncomfortable, and they say to me, "Doctor, isn't my baby big enough to deliver?" Well, you can see here, it's not the size of the baby that's important, it is the maturity. And these big babies can be immature. This picture shows so well the difference between a IUGR, small for gestational age, baby from a woman who has long-standing type 1 diabetes with small vessel disease and a macrosomic baby of gestational diabetes or type 2. And yet both of these babies may be side by side in the intensive care nursery because of immaturity. Here's a baby of a diabetic mom, 14 pounds almost. Here's one weighing 14 pounds, 3 ounces. Here's one that weighed 14.5 pounds from Cancun, Mexico. Here it is. They call this baby Supertonio. This was a 17-pound baby from Brazil. The giant. This baby walked out of the delivery room. You know what the biggest baby on record that was delivered? 23.75 pounds. This was in 1879. The mom was 7 foot 5.5 inches tall. How tall is Shaq? Shaq is 7'3", I think. So this was a very big woman. But the baby died at 11 hours of age. What do you think it died from? This is probably gestational diabetes. This is probably respiratory distress or hypoglycemia. One of the concerns we have is to predict macrosomic babies. And this table looks at how accurate are we in estimating fetal weight. And this study looked at 3 ways of assessing fetal weight. Clinical, and this is where the doctor feels a mother's uterus and says, I think this baby is probably around 8 pounds. The second method was to look with ultrasound and give an estimated fetal weight. The third was just to ask the mom, what do you think the baby weighs? Now this is women who've had previous babies. And here is how accurate they were. What percentage of the estimates were within 10% of actual weight? Clinical, ultrasound, ask mom. Is there a significant difference? Not a whole lot. We have a long ways to go in accurately predicting macrosomia at this point. Okay, let's summarize what we've just said. Screening test for gestational diabetes, 1 hour 50-gram oral glucose tolerance test. Who gets it? Everybody. What gestational age? 24 to 28 weeks. If the value is less than 140, gestational diabetes is ruled out. If it is 140 or greater, the next step in management is 3-hour 100-gram oral glucose tolerance test. Out of those 4 values, if 2 out of those 4 or more are elevated, gestational diabetes has been diagnosed. Now we need to educate the mother regarding home glucose monitoring, a diabetic diet. Then we want to see what her blood sugars are. The target range is less than 90, less than 140. If her values are consistently above that, we will start insulin. Does she have risk factors for fetal demise? What are those risk factors? If she is on insulin, if she has coexisting hypertension, if she had a previous baby that died in utero, we want to start at 32 weeks, NSTs and AFIs twice a week, non-stress testing and amniotic fluid index. Make sure the baby's okay. In terms of labor, our concerns are arrest of stage 1 and stage 2 and shoulder dystocia. If we estimate the fetal weight is over 4,200 grams, we may very well want to do a scheduled cesarean. But remember, our accuracy is less than optimal. Postpartum, we want to prevent postpartum hemorrhage. Be ready for that. Have your medications ready. And then we want to make sure she doesn't have persistent glucose intolerance. Check her fasting blood sugars or do a 2-hour 75-gram oral glucose tolerance test. And that is the end of diabetes in pregnancy.